Good morning, everyone. Happy Thursday. Welcome to round one bajillion of Thursday VMR. Just realizing that we're approaching the 5 year mark, which is absolutely berserk and crazy. Um, but I'm very excited today to discuss with a mentee who is as ancient as VMR itself, Dr. Kirtan Patolia. It's almost crazy to introduce you, Kirtan. You need no introduction. But I was reflecting both on how long VMR has been going on, but also how long I've had the privilege of knowing you and working with you. And it's been really incredible to see the promise and the potential become real. And I think very, very many people have a tremendous amount of enthusiasm for clinical reasoning early in their training, but many other people go on to specialize in different domains and still love internal medicine, but become and evolve into other things. I think what's been so powerful about you is you are as consistent as VMR every single day for many, many years, head down. And I'm very, very excited to share the stage with you. But I think we're both very excited because we have a new time first case presenter. So before I introduce our case presenter, I'll hand the mic to Kirtan to say hello, and then we'll get to meet our new friend.
Sure. Thank you for the kind words, Abhi. Good morning, friends. Thank you so much for joining. It has been a privilege to be part of CP Solvers. And like as Ravi was saying, that I was always enthusiastic, but I must say that my enthusiasm has blossomed more and more after joining the CP Solvers. And I'm very grateful for these precious opportunities that I get every single day. And I also wanted to thank Promise for helping with Skyping today, Mukund for teaching points. And yeah, Jonathan, like so excited. Please tell us more that where are you joining from, which stage of training you are in, and what made you come to the CP Solvers?
Hi, so actually I'm from the Philippines, so good evening to everyone. So it's already good evening here in the Philippines. So yeah, you can just call me JP. So a lot of my friends just call me JP rather than Jonathan. I'm more accustomed to it actually. So I just received my step 3 results and I passed it. So yeah, that's one of my achievements actually for today. And I'm really excited to with you guys my case. So actually, I'm a pathology resident here in the Philippines. I'm on my fourth year, and I think the interesting part of my life right now is that I'm pathology resident transitioning into an internal medicine residency in the US. So I think that's the interesting in my application. I'm trying to make it work actually. That's it.
Kirtan, I think today tissue is the issue, but maybe
Sure,
Yeah.
always.
but maybe not because the last minute twist of from tissue to the bedside in internal medicine. I don't know if I've ever heard that, JP. That's really, really cool. I imagine you have a very rich case, but I can't let that go. I'm really curious, what inspired your transition from pathology to internal medicine?
Um, actually, I did a pre-residency in internal medicine here in the Philippines because actually it's one of my passion. But because of the pandemic, and since I'm living with my parents who have a lot of comorbids, I need to step
Mhm.
down of the clinical side of medicine, and I
I
opted to go to non-clinical side,
Mhm.
and I think that's a blessing in disguise because it gave me time to review for the step exams, and I think that's my advantage.
Yeah.
Having a diagnostic acumen going to internal medicine, I
Right.
think that's an interesting side of it.
Amazing. Well, you said the right words, diagnostic acumen. Oh my God. I feel inspired already. That's really cool. Oh, Kirtan and I have very restricted but very full lives outside of outside of medicine. What are your hobbies outside of medicine?
Actually, I'm a volleyball player.
Ooh.
Yeah, I
uh,
do volleyball player. I was a varsity player when I was in med school
yeah.
and still continuing playing volleyball in our hospital actually. So we have this sports festival. I joined them representing the medical division, then
Nice.
representing the hospital itself to various inter-agency sports competition here. So it's our hospital versus other hospitals in the region.
Yeah.
So yeah, I think that's it. Then I love making videos. So I do fly drones sometimes.
Oh,
So
cool.
yeah.
That's really, really cool. Wow, I feel like you're going to ace your interview. I feel like we just had a mini sample of what your interview is going to be like. Amazing. Well, let's jump right in. Thank you, Promise, for scribing, and Mukund for teaching points. We can start to hear your first aliquot, JP. You can get going, JP. It's okay. We can always catch up later. Yeah, go for it. Ooh. Here, I'm gonna help you stop sharing because I think you're revealing a lot of the case. Yeah, JP, you should probably stop sharing. Yeah, there you go. I turned away. Then Kirtan looked down. Um, Promise, are you able to share your screen?
No, it says a host disabled.
Oh, I see you logged in from a different account. My bad, my bad. All right, one sec. I'll make you a co-host now. All righty. Wow, it was so tempting not to look. Oof. I promise you should be able to share your screen. JP, by the way, thank you so much for the we got a snippet of just the sheer amount of prep you did for this case. Gosh, wow, that looks like quite a bit of work. Thank you for all that you did to make that happen. Now we get to go for it piecemeal. So why don't you give us what you have for aliquot number one?
JB, I think you are muted.
Yeah. Okay. It's fine. Yeah. So good morning. Good morning, guys. So this is a case of a 17-year-old male presenting with a submandibular mass. So initially, the mass was described as like a pimple. So it's a pimple-like mass in the submandibular area. So for the history of present illness, last July of 2020, so that's approximately 5 months prior to the initial consult. So the patient presented with a right submandibular mass. So the patient self-medicated with an unrecalled ointment. And apparently, it got resolved initially. Last September of 2020, so that's 3 months prior to admission, the patient noted resumption of the mass with gradual enlargement with no other associated symptoms. Because of this, the patient opted to consult with a private medical doctor where a neck ultrasound and a fine needle biopsy was requested. The neck ultrasound revealed cystic mass, while the fine needle biopsy report showed multiple severe inflammatory cells consistent with a bronchial cleft cyst. Last December of 2020, the patient presented with a gradual enlargement of the said mass, now presenting with dysphagia and discomfort. Because of this, the patient followed up to his private doctor, where a neck CT scan was requested, revealing multiple lymph nodes at the submandibular area. So the exact mass, the exact imaging results said that it is a well-delineated lesion in the left lateral neck, anteromedial to the sternocleidomastoid and lateral to the jugular and the carotid vessels, compressing the internal jugular vein. The enhancement is consistent with an enlarged lymph node. There are also several lymph nodes noted on the CT scan. For the past medical history, the patient presented no comorbidities and she reported no previous hospitalizations. Currently, the patient have no medications, while the family medical history and the social history are unremarkable. For the health-related behaviors, the patient reported that he has multiple sexual multiple sexual partners, both men and women, with no allergies.
JP, is this
For the
where?
fifth,
Oh,
yeah,
do you have a sense? Maybe we can stop here for the first aliquot. Is that okay with you?
okay.
Yeah. Did you have another plan for when you wanted to stop?
No, it's fine.
Okay, perfect. All right,
Yeah.
wonderful. Yeah, Kirtan, I'm curious. We got a lot of information. I'm curious if you wouldn't mind trying to summarize what you think is relevant so far. What have you grabbed onto, Kirtan?
Perfect, sure. And before I do that, JP, just one clarification. You said this person is 17, like 17, or is it 70?
Oh, it's 17, 17.
One sub, yeah. So that makes a big difference, knowing that
Yeah.
somebody is young versus somebody who is old. Yes. So to summarize, we can say that we have a very young person who is presenting with chronic symptoms, and those symptoms comprise of a mass-like lesion in the left submandibular region, and we could kind of put it as like head and neck stuff. So head and neck mass, which has been progressively enlarging, which has inflammatory features based on the preliminary FNA and the enhancement which was seen, and now the interval development of multiple lymph nodes as well. So I think that is how I will summarize. And there are various ways in which we can approach this problem. So first thing is to get the story straight. So we have to determine that whether the process which was cystic in the nature first later on evolved to cause lymph nodes is the same process, or is it a different process altogether, and maybe there is no complication of the first process. So that way we could figure out that what's going on. Now, when it was reported first time as a cyst, the presumptive diagnosis was brachial cleft cyst. So we have to understand that are these features consistent with brachial cleft cyst? And if it was brachial cyst itself, then why now there are lymph nodes? Did it get infected? Because we know that brachial cyst could have hematogenous transformation, lymphomatous transformation to malignancy, as well as it can get super infected, and that can cause this lymphadenopathy. But surprisingly, patient never reported fevers or any other constitutional symptoms. So that makes you wonder that since there is no severe redness in that region, no fever, maybe infectious causes are on the backside. And then you start wondering that what if there is indeed a neoplastic cause going on with all this lymphadenopathy. And the most concerning thing which JP mentioned was that patient has dysphagia, and the imaging findings were consistent with compression of the vascular structures. So whenever there is compression, you start wondering that is there an invasion as well? And if there is an invasion, then you start wondering that could this be malignancy or not. Now, the other thing is that everything started with person noticing a pimple in the first region. So that's another thing we have to ponder upon, that whether there was an abscess developing there and there was a skin breakdown. That's why infection went inside and caused all of these things. So this is where I am lingering right now, that whether it's a malignancy or it's an infection, and which kind of infection, which kind of malignancy, we can determine further once we have some basic examination findings.
That's absolutely amazing, Kirtan. Thank you so much for clarifying that. I imagine that people are probably maybe familiar with the words of brachial cleft cyst, but I'd be curious to know what you can share with us about your illness script. So, because I think understanding that diagnosis will help us a lot. So, what can you share? Maybe just take a moment or two to just share what you know about that condition.
Oh, yes. So I remember that in embryology, when our body is developing, there are different brachial clefts which develop in bilateral cervical region, and eventually they end up into different structures. Like some of them end up creating the vestibular auditory tract, some of them end up creating pharynx, larynx, and they also give rise to the muscles of the cervical region. So usually when somebody is developing, and by the time a person is born, all these brachial clefts is kind of obliterate. But if they do not obliterate, so it means that it is a remnant, embryologic remnant, kind of like thyroglossal duct cyst. And when it's a remnant, in most of the people, it would be actually benign because it's just sitting there, not causing anything. But in some people, either it can undergo enlargement, it can get filled with the fluid. If that fluid could be just simple brachial cleft fluid, non-infected, or it could get infected. And then since the lining of the brachial cleft is squamous cell in origin and some amount of endothelium as well, so you could imagine that if there are squamous cells, it could undergo transformation to squamous cell carcinoma. And if there are endothelial cells, then it could undergo transformation to lymphangioma, lymphangiosarcoma as well. So I think that is what we have to understand, that since it's an embryological remnant, there are various epithelial linings which are component of it, and all of them can undergo transformation to neoplasms.
That's wonderful. Excellent. And thank you for shedding light on that. You also were shedding light on what you might worry about in patients who have a space occupying process in their neck and what complications can develop from that. And I think if you were seeing this person for the first time, you would probably have to put a pause on the diagnosis and wonder what complications can happen from any space occupying process in the neck. So do you have a way of simplifying that or breaking that down that we can start to shed light on in this case?
Sure. So I don't have like how to say a well delineated schema, but usually I try to think of it as that what are the anatomical structures in the neck space and how they could be affected. So first bucket I consider always is the vascular bucket. So we know that inside the neck, we have so many vascular structures traversing between the thoracic cavity and CNS. And if we think about the carotid sheet, then you could imagine there is internal carotid artery, there is jugular vein, and there are lymphatics going on. So if you have encasement of those structures, sometimes people can have thrombosis in that region, people can have thrombophlebitis, and even strokes and hypoperfusion symptoms. If the lymphatics are involved, then people can have engorgement in that area, edema, swelling, and discomfort. So this is about the vascular structures. Then you move more medially in the central part of the body, then you get to the airways and the GI tract. So you think about the upper part of the esophagus. So people can have dysphagia. Then you think about trachea and larynx and pharynx. Then you can have stridor, you can have aspirations, difficulty in taking breaths. And then if you go further down into the thoracic cavity, then you have upper mediastinal structures. So people can have mediastinitis. And once you have mediastinitis, it is very bad prognostic sign because inflammation could rapidly spread to the pericardium space and other lymph nodes in the mediastinum as well. So that's how I begin. I start with the peripheral structures like vascular, then I move to the central part. And this is all considering what is happening inside. If you consider outside of the body, then you come to the skin and subcutaneous tissue. So whatever inflammation is going on inside the neck, it could leak or seep into the outside structures, and you could have abscesses forming, you could have cutaneous fistulas going on, especially if there are abscesses and some granulomatous infections going on. So that's how I approach.
Yeah, it's amazing how much the neck carries. It is a highway between the head and the chest and carries air with it, blood with it, neurological impulses with it. And essentially, if you interrupt that highway, you can interrupt airflow, blood flow, and importantly, sometimes electrical conduction from the head to the neck, which is important because you can get diaphragmatic paralysis as well, and also vocal cord paralysis. So I love that anatomical approach, and just really emphasizes just how many the neck is just like the brainstem. It has packed full of really, really important structures. I think Kirtan, one really interesting dimension of this case, and I'm really curious to get your insight, is JP has been talking about the neck and the neck and the neck and the neck. Are you framing this as a neck mass, or are you open to the possibility of this being a systemic disease with cervical manifestations? And I'm curious what your pre-test probability is of finding other problems elsewhere outside this dominant cervical location.
Yeah, sure. So, Rabi, as we were discussing in first aliquot, that the first and foremost question we have to answer is whether this brachial cleft cyst is the only thing which caused the lymphadenopathy, or is it something else going on entirely? So, I think I cannot say with certainty that the pretest probability of having an extra cervical problem is high. But given that there are multiple lymphadenopathies, and especially in the bilateral region, that does make me wonder if there is something going on outside, because you could wonder that if there is a brachial cleft cyst, and even if it is infected, you should have unilateral manifestations. But having bilateral lymphadenopathy, so, and all this chronicity of symptoms suddenly makes you wonder if there is an extra cervical problem. And the classic things to consider would be in a young person, that what are the autoimmune and what are the neoplastic conditions which have predisposition for the cervical lymphadenopathy and mandibular region. So we don't have to go into details of that because there are certain specific infections which have predisposition for head and neck region and certain malignancies which also a predispose for head and neck region. So all of them are on the table given the diffuse lymph nodes, and especially the fact that FNA was never conclusive. Like all we saw was inflammatory cells, some brown cells. So we don't know what they actually represent.
I completely agree with you. I think we have to be very, very careful not to get tunnel vision and literally think about the tunnel between the head and the neck alone and think about where else this problem could be. I think the more and more the syndrome is centered around the neck, and the more and more that the story doesn't take on a different feature of abdominal pain, nausea, vomiting, anorexia, weight loss, the more and more you start to center in on the neck itself. And I think it's going to be very, very important in this patient to zoom out, both be attentive to complications that you outlined, but also not to ignore any signals that tell us and can clarify the disease outside the neck. And I think that's what the role of the exam is in this situation, is to understand what's happening in terms of complications, but to make sure we look for inguinal, axillary, and epitrochlear even lymphadenopathy, as well as getting a general sense of how much this has affected the person. Is their BMI normal, or is it low? And I think those are going to be really, really powerful clues. Thank you for a really a rich first aliquot, JP. Maybe you can just give us the exam next, so we can analyze that and then move on.
Okay, thank you. Well, to answer some of the questions in the chat, so regarding the protection, according to the patient, inconsistent use of protection during sexual contacts. Okay, so for the examination, so the vital signs, so the temperature, heart rate, the temperature for the patient during consult was 37.4 degrees Celsius. However, on further examination for the patient, on further follow-up, there were febrile episodes at around 37.9 to 38.1 degrees Celsius. For the heart rate, it's normal at ranging from 70 to 80. For the blood pressure, the patient's normotensive with a normal respiratory rate. For the examination, so we're just gonna focus first on the head and neck areas. So there was a 6 by 5 centimeters solid, non-tender, non-erythematous mass at the left submandibular area. To further characterize the mass, it is fixed, does not move in deglutition, with regular borders. For the cardiovascular, pulmonary, and abdominal exam, they were all unremarkable. And to answer some of the questions regarding the lymph nodes, there were no other lymph nodes palpated on the axillary and the inguinal areas. For the extremities and skin, all were normal.
Thank you so much, JP. Thank you for the detail. Kirtan, I'm curious now, if we can just try to answer the questions that you laid out. Are you, I'll just say them all and then you can answer them in whatever order you like. Are you seeing any complications of this mass? What is your pretest probability of this mass being the center of gravity or just part of the systemic story? What do you think about those two things?
Sure. So first thing, Rabih, from the information that we have so far, I won't be keen to say that this patient has developed some complications. We already know that this person had a big mass, and it was in fact big enough to cause dysphagia to begin with. And I'm not saying that patient has any dyspnea, any tachypnea, any hypoxia, or any discomfort on general examination to suggest that imminent danger is present. So that's my first thing. Second thing is whether this is center of gravity or not. So I think now we are getting more and more flavor of the same thing, because JP told us that all other areas like inguinal, axillary doesn't seem too much involved. Patient doesn't have any striking constitutional symptoms going on. Cranial nerve examination is fine. So it doesn't seem like this mass is invading anywhere. It is just sitting there. And given the fact that this is a fixed, hard lymph node kind of structure going on, because I think in the first aliquot, JP told us in the last part that in the like sternocleidomastoid muscle, there was this well delineated lesion compatible with enlarged lymph node. And now this examination is further raising the suspicion that this does seem like a very enlarged lymph node. The reason why I'm saying that, because if this mass was originating from, let's say, mandible, then you would expect that there is some degree of continuity there and maybe some degree of fluctuance. Examination can definitely not clearly delineate the borders of the mass, that where it is originating from, but from the story it looks like that is indeed a lymph node. So we can kind of put the center of gravity on the fact that this is an enlarged unilateral chronic cervical lymph node. And if we have that in my mind, and if you look at the past medical history, then that does shed some light that this person has been having multiple sexual encounters and especially unprotected. So you start wondering that what are some of the infections that person can get. And most likely you think about HIV infections and other viruses which come along with it. So you start thinking about the herpes simplex group of viruses, classically EBV and CMV. And this is where what we're discussing in first aliquot comes into the picture, that there are some malignancies and some autoimmune diseases which have predilection for the head and neck region. So that's why EBV was something which was garnering my attention, that maybe this person could have EBV infection, like occult EBV infection going on, and which now is resulting in neoplastic complication. And there are so many lymphomas that EBV can cause, which can classically hit the jaw and submandibular region. So that is what I'm thinking, that maybe I will do some serological testing. And if I get the HIV positive, then suddenly I will go down a different path, and this hypothesis will become even more robust.
Love that. I think that's superb. I have nothing to add to that, but I think to help one piece of advice for all of you who, if you were taking care of this patient and are wondering, does he have any anatomical complications? Sometimes patients don't have anatomical complications of masses at rest, but they may be positional. And I think in order to safely discharge this patient, say from the emergency room, if you were thinking that an outpatient workup is necessary, you would need to prove that this mass doesn't cause any anatomical compression in the most vulnerable position, which is lying down. And so I think that you could be easily fooled if you did this exam sitting up that the patient has no symptoms, but I would be inclined to have the patient lie down to make sure that there wasn't a threat to the airway. I think it's very helpful, Kirtan, that aside, to ask ourselves, are we going to get a productive workup systemically? So I completely agree that you need to do that, but I'm curious, before we hear the labs from JP, what is your pretest probability of a very binary question? Do you think the labs will be overall positive or overall negative? And what would be your rationale for that, for your prediction?
Sure. So I would say overall they will be negative, and probably my rationale would be, first thing, that patient doesn't have systemic signs and symptoms going on. No fevers, no night sweats, nothing like that. Second thing, from the examination, it looks like that this mass is localized to that region. And the other part, which I'm not saying right now, but based on the diagnosis which we have in our mind, the preliminary diagnosis, we know that there are certain, let's say, lymphomas or certain infectious conditions which usually stay limited to one anatomic region, and they don't leave a signature on your reticuloendothelial system. They don't leave a signature on other organs. So you could presume that the CBC would be unremarkable, LFTs would be fine, because maybe whatever the process is going on, it has not disseminated into the bone marrow and into the blood as such. So you won't see any systemic signatures.
Completely agree with you. I think this case is a very interesting paradox. This disease process has decided to take up 6 by 5 centimeters in this person's neck, enough to cause compression of the esophagus, but has decided not to cause any weight loss, any anorexia, or any fingerprint. In some ways, if you just took it out, it seems like if you just take it out from here, you solve the problem, which is fascinating in that it really helps you formulate your differential diagnosis, and understanding why this thing has chosen to grow so much locally and has chosen not to go and flick off other places is very, very intriguing and a very powerful clue to what this criminal actually is. But what's the paradox? The paradox is, despite not deciding not to go elsewhere, it is able to mount a systemic inflammatory response with a low-grade fever. And I think seeing that paradox for what it is very interesting and really will be a powerful combination of things. Systemic features in a fever, yet no systemic dissemination. And that paradox, at first glance, needs to be challenged and to say, are we dealing with a sneaky systemic disease that is under our detection radar? And it would have to be sneaky, which would mean the labs would have to save us from the correct default assumption that this is actually a disease centered in the neck. And it might force us to prioritize conditions that cause a fever through cytokine or paraneoplastic mechanisms, i.e., that the fever is not proportional to the systemic fingerprint of the disease process. And we see this, as Kirtan said, with some characteristic malignancies, but we see it much more commonly with mild viral infections. If I tell you your patient comes in with a fever of 39 degrees Celsius, and I tell you they have a URI and a cough, you'll be like, ah, it's probably a virus. But if I tell you they have abdominal pain, we'll panic, right? And so I think that the question to summarize is this a disproportional fever? And this is a disproportionate inflammatory response, prioritizing some infections and some malignancies? Or have we underemphasized the systemic fingerprint of this disease, which will show up on labs or imaging tests? I agree with Kirtan. Based on our ability to detect the systemic fingerprint by talking and examining the patient, there doesn't appear to be one, but those tests are good and not perfect. So I think the next phase of this, Kirtan, is to really understand what is the ratio of the fever to the systemic disease. And right now, it is seeming that this is a disproportionate propensity for a fever. Alrighty, JP, tell us a little bit more, please. Maybe actually, JP, you can just give us the labs since we are very intrigued by them as for the next aliquot, and then we'll try to make a more refined guess. Is that okay?
Okay. Okay. So I'm gonna reveal all the labs and imaging for this portion.
Okay.
So for the hematology, for the complete blood count of the patient, so the patient has a WBC count of an 8.9 with a low hemoglobin of 118. So the WBC picture of the patient is lymphocytic predominance with a normal thrombocyte population. There were no atypical cells or blasts noted on the peripheral blood smear of the patient.
JP, just one clarification, sorry. The hemoglobin was 11.8, is that right?
Yeah.
Okay.
118. I'm sorry, it's 118.
Yeah, gotcha. Yeah, so I think translated to US units, it would be 11.8.
Yeah, actually, yeah.
Very good. And I missed that. So can you say what the differential on the CBC was? I missed that. I'm sorry.
It's lymphocytic predominance.
Okay.
Yeah, it's lymphocytic predominance.
Okay, thank you. Sorry about that.
Okay. So for the chemistry of the patient, so only electrolytes and a creatinine was requested for the patient. So a creatinine of 1 is noted for the patient with a normal sodium of 132 and a potassium of 4.0. For the imaging of the patient, for the neck ultrasound, so the neck ultrasound was repeated for that patient. So there was a mass, a heterogeneous mass noted on the submandibular area, approximately 6.2 by 5.2 centimeters in widest dimension. There were also notable lymphadenopathies, aside a smaller lymphadenopathies surrounding the mass on ultrasound. On CT scan, it was again repeated, revealing the same findings as the initial CT scan, revealing a heterogeneous soft tissue mass, post-contrast enhancement consistent with enlarged lymph nodes with multiple lymphadenopathies surrounding it. There were no ECG and chest X-ray noted requested for the patient. So after this, we already actually for the next part is the excisional biopsy already for the patient.
Okay. All right. So let's spend a little bit of time here before you tell us the excisional biopsy. And Kirtan, maybe at the end of your analysis, you can share we know already from JP that they did an excisional biopsy, which is the right move. But maybe you can share what other options you have and why excisional biopsy is probably chosen for this patient. So I'm curious, I'll just hand the mic to you. What jumped out to you, and how are you thinking about this case?
Sure. So maybe JP, I can ask you one clarifying questions that where the HIV, hepatitis, and syphilis, like these three serologies, basic serologies obtained or not?
Actually, yes. I'm sorry for that. I missed out.
That's all
So
right.
so syphilis, HIV, and hepatitis panels were all non-reactive.
Good. That's good to know. Thanks for sharing that. Yes. So this is a good point to summarize where we are standing right now. So we have a young gentleman who presented with subacute to chronic presentation, and the presentation was dominated by symptoms in the head and neck region and fevers. And in the head and neck region, through the advanced imaging, physical examination, we were able to reach to the conclusion that this person in the end has a soft tissue masses in the left mandibular region with accompanying lymphadenopathy. So now our job is to figure out that what are the conditions which can cause this soft tissue mass-like lesion in the head and neck region coupled with the fevers. So initially, I was wondering that could this be infection or not? Then we were thinking about autoimmune conditions and we were thinking about neoplastic conditions. But now, since we are nearing the end of the case, we have to put our emphasis on certain pivot points of the case. So I would say that in this case, the pivot point is that, as Rabih was pointing out, that there is discrepancy between the degree of systemic involvement versus fevers, raising the suspicion that maybe it is the cytokines which are causing the fevers. And secondly, a mass-like lesion in the head and neck region. What can cause that? So if we frame our differential in that way, then the first thing which we have to wonder is, could this be a neoplasm? And if it is a neoplasm, then it is the hematologic or solid neoplasm. So if we think about the solid neoplasm in head and neck region in a young person, the first and foremost concern that you should have is this a squamous cell carcinoma? Now, good thing is that we know that this person didn't have smoking. We don't have any evidence of person having papilloma virus. So that makes squamous cell carcinoma lower on the differential. Second possibility is, could this be a germ cell tumor? Because young people, they often can have masses hiding in the testicular region, and no matter how advanced imaging you do, but if you don't do testicular ultrasound, maybe you can miss it and it could have metastasized to this region. But usually when there is metastasis of the testicular neoplasms, you would also see signature in the retroperitoneal lymph nodes because that is how the drainage works. The fact that so far we have no lymphadenopathy anywhere else also makes that testicular neoplasm hypothesis less likely. So after ruling out these two common solid neoplasms, I would move to the hematologic neoplasm. And in the hematologic realm, you start thinking, could this be lymphoma versus could this be leukemia? Now, in the leukemia part, it's tricky. We always look at the peripheral blood smear. We say that counts are. I think Paula? Yeah, okay, thank you. Yes. So often we think that, well, the blood smear is looking good. There are no blasts. So maybe this is less likely to be leukemia. But we might be fooled because there are aleukemic leukemias, and sometimes the cells could be hiding in the bone marrow. So if this is indeed a leukemia, then classically in young people, you think about lymphoid leukemias. And often BALL and TALL can present with masses. But usually, again, those are the mediastinal masses, not cervical masses. So once we move past the leukemia category, then we come to the lymphoma category, which has been more and more alluring throughout the discussion. So what kind of lymphomas would cause this? So we start thinking about the aggressive lymphomas, and then we talk about indolent lymphomas. So for indolent lymphomas, we often think about follicular lymphomas, marginal zone lymphomas, and usually these lymphomas tend to be disseminated. Like it's hard to find follicular lymphoma just sitting in one lymph node. And since it is indolent, it would be very tiny. Usually they are not big, massive, bulky lymphadenopathies. So then you move to the aggressive lymphomas. And in the aggressive lymphomas, usually we think about three lymphomas. One is diffuse large B-cell lymphoma. Second is mantle cell lymphoma. And finally, we talk about Burkitt's lymphoma. So these are the three conditions which we have to put our focus on. Now, DLBCL is notorious to cause the systemic fevers because of the release of interleukin-6 into the circulation. But again, DLBCL, as the name suggests, it is diffuse. So often people have involvement of mediastinal, axillary, inguinal, liver, spleen, and sometimes even bone marrow causing pancytopenia. So we are not getting that signature. And even the age is a little bit odd because DLBCL, as far as I remember, it doesn't present this early in the life. Then we move to the mantle cell. Mantle cell is tricky. It could present in young people, and mantle cell lymphomas can definitely fool you. It can present in whichever way possible, sometimes just located to cervical region, mediastinal region, even CNS. So mantle cell lymphoma is something that we have to consider. And then we come to the Burkitt's lymphoma. So the reason why I kept Burkitt's lymphoma for the last was because in my mind, that was something which was more plausible in this case. Because Burkitt's lymphoma has predisposition to affect either the jaw and neck region or the abdominal region, depending on which part of the world you are coming from. In Asian countries, often you find that people have abdominal masses like arising from the ileum and colon and causing GI symptoms. Whereas in Western population, often you find that people have mandibular and jaw masses. And Burkitt's lymphoma, because of the fact that it is a high-grade lymphoma, often there is so much turnover just located in one particular lymph node that turnover is enough to release cytokines and cause fevers. And in some people, even constitutional symptoms like weight loss. And the ideal way to diagnose Burkitt's lymphoma is what JP's team did, is excisional lymph node biopsy. And this is because Burkitt's lymphoma rarely invades the bone marrow. It rarely invades the blood itself, and it rarely invades the liver and spleen. So you could imagine that there is nothing else that you could biopsy, and there is no signature in our workup as well. So that's why external lymph node biopsy is useful. So this was about lymphomas. Regarding other rare possibilities, there are some conditions which can come in Asian populations in the localized region. For example, you could have Kimura's disease, you could have Kikuchi's disease, but Kikuchi's disease usually is very inflammatory. People have concomitant lupus, people have cytopenias, high ESR-CRP. We are not getting that flavor here. Then this Kikura, I forgot what I was saying. Kikuchi, Kimura, yes. So
Kimura.
Kimura's disease.
You merged them. It was beautiful.
Yes, I fused both of them. Yeah. So Kimura is something that can happen, and we will have to biopsy that eventually. And then lastly, we think about, could this be histiocytic disorders as well? So there are some histiocytic disorders like Rosset-Dorfman disease, which are predisposition for cervical lymph nodes. But again, like this big lymph nodes, I have not been familiar that they could cause this big lymph nodes, but I will keep them at back of my mind that could this be histiocytic disorders or not. So Ravi, that was my basic framework. So what are the other entities that we should keep in mind with this big and large lymph node?
Absolutely superb. I think that you really the journey that you just took us on of how you went from least likely to most likely is really a model for everybody who is listening. That's how we structure our assessment and our plans and in our presentations all the time. Like this is the, and then you ultimately make a case for what you think is going on. And the teaching that you had peppered throughout it was superb, ending with the conclusion that you're most suspicious of a lymphoma. And I'm right there with you. I just wanted to not spend any time re-emphasizing what you said because you said it so well, but to clarify one other different thing that may cause some confusion, which is the terms in the radiology report of mass and lymph nodes. And you might be saying, oh, like the patient has mass and lymph nodes. It must mean that the mass is then disseminating into the lymph nodes. But JP is teaching us through his astute radiologist that sometimes lymph nodes can congregate to form what's called an aggregate lymph node that really mimics the mass. And so either this mass is a massive lymph node, or this mass is a tightly bundled up conglomerate of lymph nodes that is becoming so large that it is taking up a mass-like phenotype. So, said in simple terms, the combination of mass plus lymphadenopathy often reflects a space-occupying process with disseminations into the lymphatic system. Less commonly, but more likely based on the radiographic imprint in this case, that the mass and the lymph node are the same thing, but the mass represents a large accumulation of lymph nodes mimicking a mass-like structure. And that's why Kirtan is very confident by saying, hey, this is still a lymphoma, despite the fact that this person has mass plus lymph nodes, which is often evocative of a solid tumor. So just wanted to clarify that that is a radiological distinction, but we could be wrong. And that's why Kirtan is open to a solid tumor, like germ cell tumor or squamous cell, less so, but that's why that is a possibility. That turns out not to be a conglomerate of lymph nodes, but turns out to be a space-occupying solid process. I think the other dimension that caught my eye, Kirtan, just to, because I know Promise has to leave, just to speak briefly, is the lymphocyte predominant CBC. Whenever we see lymphocytic predominance, we know that's abnormal. And the key question to try to emphasize is that acute lymphocyte predominant, or is it subacute or chronic? Most patients who have acute lymphocytic predominant disease have mononucleosis. Chronic lymphocytic predominance is often evocative of a monoclonal population of lymphocytes that should not be there consistently, further reinforcing Kirtan's suspicion that this is a lymphomatous process. It is not unheard of, actually very well described in VMR, that lymphocytes on the smear are actually blasts, and the smear misread them, which is why it's important to be, as Kirtan said, to be open to the possibility that the initial read that these are lymphocytes are actually blasts. But as Kirtan said, this case is much more compatible with a lymphoma than it is a leukemia. So the question is, how does that help us? It helps us further prioritize what Kirtan said about lymphoma, and it helps us apply yet another filter of what this lymphoma could be. And it becomes a question of, well, what are the most common lymphomas that secrete their lymphocytes into the bloodstream? And of course, that's an assumption. We haven't proven that yet, but that's yet another filter to apply this case. The most common cause of lymphomas that secrete their lymphocytes into the bloodstream is CLL, chronic lymphocytic leukemia. And its cousin in the lymph nodes is called SLL, small lymphocytic lymphoma. That is not at play here simply because of the patient's age. CLL is almost unheard of in patients less than 50 years old. What is my best guess as to what this cancer could be? I would just say, Kirtan, that I actually don't know with confidence, but I think there are a couple or maybe three features that have me most worried, honestly, about Hodgkin's lymphoma. The reason I'd be worried about that is what we talked about earlier. The ratio of fever to systemic complications has me worried most about the idea that most of this inflammation that this patient is having is not neoplastic, but paraneoplastic, meaning that the amount of fever is out of proportion to tumor burden, a feature that's evocative of the Pell-Epstein fever in patients with Hodgkin's lymphoma. And the other feature that has me considering Hodgkin's lymphoma is yet another characteristic feature, which is the slow, deliberate, contiguous spread, slowly taking up space in this patient's neck over many, many months. But I think most telling is just how hard it has been to diagnose. And that latter fact actually connects with the former fact. Hodgkin's lymphoma in most patients is a few cancer cells surrounded by a chaotic inflammatory response. And that chaotic inflammatory response camouflages the ability to detect the smaller population of malignant cells. So I think this case is going to be a tension between a very well-described syndrome of endemic Burkitt's lymphoma causing a space-occupying mass in the neck versus Hodgkin's lymphoma with its propensity to cause tremendous paraneoplastic inflammation from very little tumor. I'm curious, since we have a few minutes, how you're balancing this very nuanced tension, which is ultimately only valuable for the pathologist because they're going to have to decide how much they scrutinize this tissue. Burkitt's lymphoma shouldn't be hard to see, but Hodgkin's can require a lot of effort on their part to find those small number of Reed-Sternberg cells. So I'm curious, what is your take of the tension between these two conditions before we hear from JP?
So Ravi, actually, when we were thinking about HIV and herpes group of viruses, that is where I was leaning towards that could this be EBV-related lymphomas? And in EBV-related lymphomas, we talk about like Burkitt's and then some of the Hodgkin's lymphomas as well. And I was thinking that we often learn about the histologic subtypes of Hodgkin's lymphoma, and we have nodular sclerosing type, we have cellular type. And since, as you said, this is a little bit atypical, it is just located in the neck region. If we don't see anything in the mediastinum, which is the classic region where we see it, then I am inclining towards thinking that if it is indeed Hodgkin's, could it be LH type, like lymphocytic histiocytic subtype, because that is the type which is often sneaky and it can have these inflammatory manifestations as well. And maybe, Rabi, I was curious to know from you regarding this, that what's the age group in which we expect to see Hodgkin's? Does it have bimodal distribution, or is it more of the just old age?
Yeah, certainly bimodal.
Bimodal?
Yeah, maybe we can learn from the expert pathologist who diagnoses conditions all the time. But yeah, I think very likely bimodal. All right, JP.
Thank you.
Yeah, for sure. Tell us what you all did and what you found, please.
So an excisional biopsy was done for the patient. So submitted in our department revealed an ovoid tan brown to dark brown rubbery tissue measuring 6 by 4 by 2 centimeters mass with a tan white homogeneous soft cut surface. So we did the routine examination for it under the microscope. So for the description, so this is the microscopic diagnosis for this was a typical lymphoid proliferation initially. There were no Reed-Sternberg cells noted on the gross examination, on the microscopic examination, I should say. But what's striking for this is that the lymph nodes showed sclerotic germinal centers with the mantle layer forming layers, just like an onion skin pattern. And because of this, we diagnosed the case initially as a typical lymphoid proliferation, and we suggested a bunch of immunohistochemical stains in order to confirm for this. So for the immunohistochemical stains, so CD3, which stains for T cells, were positive for the T cells. So it's a T cell pattern. For the CD20, showed B cell pattern. CD30, which stains for the Reed-Sternberg cells, were negative. PAX5 tested positive for immunoblasts, while the BCL2, which stains for follicular lymphoma initially, was negative. Because of the pattern itself, it's just a reactive lymph node. We diagnosed this case as Castleman disease.
Absolutely fascinating. Thank you so much, JP. I'll get your response, Kirtan. What do you think?
Yeah, so it looks like that it is unicentric Castleman disease other than multicentric Castleman disease. Yeah, so it does explain the fevers, but is just the sheer amount of the involvement in the head and neck region that was a little bit unusual, because so far all the cases that I have come across of Castleman disease, I know that they can have bulkier lymphadenopathy, but often it is not very invasive. Like it doesn't like cross the tissue planes. But good to know that there could be atypical forms, and this is one of those forms.
Yeah, I think it just goes to show you how fascinating the spectrum of hematological malignancies is, and how easy it is to overlook Castleman's, and how hard it is to diagnose it. And you saw how thoughtful and deliberate our pathology team had to be to make that diagnosis. And yeah, I appreciate you, Kirtan, for making the distinction between unicentric Castleman's and multicentric disease. And this disease seems to be located in the neck. prognosis is very favorable for unicentric Castleman's disease compared to multicentric Castleman's disease. But let's learn from JP about what he learned and what happened to the patient.
Okay, so for this case, so we diagnosed the patient's Castleman disease. So to tell you the truth, the 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 ORL team actually doubted our diagnosis first. So because of the sheer size of the mass, and since actually unicentric Castleman disease predominantly presents in female rather than males, it's one of the reasons. Then for Castleman disease, according to our reading, it's more of the mediastinal area rather than the submandibular area. But for this case, we diagnose it as Castleman disease solely because of the histologic characteristic of the tissue, then confirmed by the immunohistochemical examination for this. So for Castleman disease, what we're lacking for the laboratory is the HHV8 test for these patients, which is a common cause of a unicentric Castleman disease. So it was not available in our institution. So that's one of the drawback for being in a third world country. But yeah, that's it. So other than that, it can be caused by neoplastic conditions. Autoimmune disorders can also be a part of can be a cause of a Castleman disease. And since this is a unicentric Castleman disease, surgery is the only treatment of choice. And currently, the patient is okay and living his normal life.
Amazing.
Thank
That's
you.
so cool. JP, this was amazing. Honestly, my favorite part was when you were teaching us how pathologists receive samples and how they analyze them sequentially from the macroscopic appearance to the microscopic appearance to the molecular patterns of staining. That was really, really cool. I really hope you consider presenting many more of your very interesting cases. I doubt that there are some that can top this incredible case, but we'd love to have you more on VMR. Thank you.
Thank you. It was my pleasure. Thank you very much.
Any parting words, Kirtan, before we pass the mic to Mukund for the teaching point?
Yes, sure. So, of course, thank you so much, John, and thank you to Rabih as well for leading me through this journey that how things can evolve. And I just want to say that I have heard this quote many times from different people that a diagnosis is only as good as the quality of pathologists at your hospital, because no matter how much clinical judgment you can have and how good your clinical reasoning is, at the end of the day, if you have pathologists who are so accurate in their descriptions and who can figure out what's going on in the tissue, because tissue is like very difficult. Like we might think that biopsy is the end of the world, that it will show everything, but that's not true. That pathologists have to be even smarter than clinicians to figure out that what is showing. So glad to hear that how Jonathan's team pushed for the diagnosis despite some initial hesitancy that is this indeed unicentric Castleman or not, but they stick to their guns. They figured out the immunostain and got a diagnosis. So kind of very motivating and inspirational as well, that you have to be persistent.
Amazing. All right, Mukund, mic is yours, my friend.
Sounds good. Thanks for the cool case, JP. So we'll just go through this pretty quickly. We started out with a discussion of branchial cleft cysts, which was assumed to be the pathology at first. Branchial cleft cysts are a component of the branchial apparatus, which is an embryonic structure that transforms into other structures as the embryo develops. There are pouches, arches, and clefts. The clefts are exterior, and only the first one really forms anything of note, the external auditory meatus. The other ones, 2 through 4, tend to obliterate in the embryonic stage, but if they don't, or if that process is incomplete, they can form cysts. These cysts are classically found anterior to the sternocleidomastoid muscle. They're most commonly found in childhood, and they will present as this pimple-like thing on the side of the neck that slowly enlarges, can be asymptomatic, but if large enough can cause mass effect and compression in the region versus superinfection versus, as Kirtan was talking about, malignancy either caused by tissues that are found inside the cyst itself or by other processes. We talked about complications of a space-occupying lesion in the neck, which can affect from a systematic perspective, vasculature, inducing thrombosis, thrombophlebitis, or hypoperfusion, the lymphatics causing edema, the airways causing stridor, dyspnea, and the esophagus causing dysphagia, which was seen in this patient. We talked about needing to assess the complications of mass effect in the supine position, where this may be worse. And we talked about diagnostic process for neck masses, needing not to miss other systemic processes that have a predilection for the neck. We got into a very interesting discussion of this patient's fevers and the fact that they are out of proportion to the systemic fingerprint of this patient's inflammatory process, with a differential diagnosis for that, including viral processes versus malignancy in the form of either cytokine release, such as TNF-alpha, IL-6, IL-1, etc., or paraneoplastic phenomena. We got into an excellent discussion of head and neck neoplasms, with solid tumors being comprised of squamous cell carcinomas, thyroid pathology, or germ cell tumors, and liquid tumors, including leukemias and lymphomas, with indolent and aggressive subtypes mentioned. And then finally, we thought about this being possibly Hodgkin's lymphoma as a result of slow and contiguous local spread, and the possibility of what we thought might be Tel-Epstein fevers, which are this cyclic, recurrent kind of 1 to 2 week time course fever patterns that are found as a paraneoplastic phenomenon and Hodgkin's lymphomas. The end diagnosis was unicentric Castleman's disease, a lymphoproliferative process that's located in a single lymph node and that's treated with surgery. Thanks all.
Amazing. Oh, that was such a great recap. I know you haven't done teaching points in a while, Mukund, but I think your teaching skills on the podcast and many other circumstances are coming in handy. That was awesome. Thank you so much for that journey. And as always, I love the headphones. It looks so cool. All right, y'all have a great rest of your day, and hope to see you next time on VMR. Bye now.
All right, thank you.